Dear students, welcome to the course entitled Molecular Perspectives on the Development, Causes and Treatment of Cancer, where you will unravel the intricate genetic and environmental drivers of oncogenesis. This program will guide you through the genetic, epigenetic and molecular mechanisms underlying cancer. It will prepare you to dive into cutting-edge research from clustered regularly interspaced short palindromic repeats, that is CRISPR-based therapies, to immunotherapy, equipping you to shape the future of precision oncology. Dear students, today's learning objectives are: analyze the molecular basis of cancer development, classify and describe the major cancer types and their molecular signatures. Then we'll elucidate cancer causes and risk factors, critically evaluate molecular mechanisms of oncogenesis and assess different stages of carcinogenesis. Later, we will evaluate conventional and modern molecular therapeutic strategies in cancer treatment. And finally, we will explore future directions in cancer research. Moving on to introduction. Tracing the molecular roots of cancer from ancient origins to modern insights. Cancer, named Carachnos, a crab in ancient Greece, was first documented in Egyptian papyri, 3000 BCE. For breast tumors. Virchow's 1850s theory of cancer's cellular origin marked a turning point solidified by the Human Genome Project in 2003, identifying over 500 cancer genes. Hanahan and Weinberg's hallmarks of cancer, that is 2000, 2011 and 2022, define cancer through traits like sustained proliferation, apoptosis evasion, angiogenesis and immune escape. Genetic mutations, for example tumor protein TP53, epigenetic changes, for example DNA methylation, and tumor microenvironment interactions drive oncogenesis. For today's researchers, these insights highlight the importance of exploring molecular targets with tools like CRISPR, offering new solutions to genomic instability and tumor heterogeneity. Global and national burden of cancer. Cancer claims 10 million lives every year. WHO's report 2022, with India reporting over 11 lakh new cases annually. A burden set to grow with aging population and lifestyle shifts. Spanning over 100 diseases, cancer arises from disrupted cellular regulation, where loss of contact inhibition and imbalances in proto-oncogenes, tumor suppressors and DNA stability genes fuel tumor formation. Mastering the molecular disruptions unlocks opportunities in diagnostics and personalized oncology, reducing cancer's global impact. Moving on to types of cancer. From a medical perspective, cancer types can be classified based on the type of cell they originated from. Therefore, cancer can be classified into carcinoma, the most common form of cancer. It originates from epithelial cells. Then sarcoma originates from connective tissues such as cartilage, fat and bone tissue. Melanoma originates from melanocytes, which are a type of cell that contains pigments, and lymphoma and leukemia originates from the cells that comprise blood, such as B lymphocytes or white blood cells. Dear students, let's talk about molecular perspectives of cancer development. Cancer arises from disrupted molecular control, driven by genetic mutations, epigenetic changes, and altered signaling pathways. Normally, cells regulate growth and apoptosis, but failures lead to uncontrolled proliferation and tumor formation. This multi-step process involves oncogenes, tumor suppressors, DNA repair defects, and the tumor microenvironment. Molecular mechanism of cancer development. Genetic mutations and genomic instability. Genomic instability is central to cancer, marked by mutations, rearrangements, and copy number changes. Students' defects in DNA repair genes like breast cancer gene 1 or breast cancer gene 2, BRCA1 and 2, predispose to breast and ovarian cancers, while mismatch repair mutations in mute long homolog 1 and mute short homolog 2 cause microsatellite instability in Lynch syndrome. The breakpoint cluster region, Abelson murine leukemia, viral oncogene homolog, BCR-ABL, and chromosomal translocation between chromosome 9 and chromosome 22 causes Philadelphia chromosome, that is T922. Fusion exemplifies chromosomal translocations activating oncogenic pathways. Then oncogenes and tumor suppressors. Oncogenes such as rat sarcoma, viral oncogene homolog, RAS, mylocytomatosis viral oncogene homolog, MYC, and human epidermal growth factor receptor 2, HER2, drive uncontrolled proliferation, whereas tumor suppressors like tumor protein TP53, the guardian of the genome, and retinoblastoma 1 gene, RB1, normally restrain growth and safeguard the DNA. Oncogenesis arises from the dual force of oncogene activation and tumor suppressor inactivation, producing the imbalance that fuels malignant transformation. Dear students, then comes epigenetic regulation. Epigenetic alterations are heritable changes in gene expression without changes in DNA sequence. Number 1 is hypomethylation of repetitive elements. For example, long interspersed nuclear element 1, line 1, promotes chromosomal instability and oncogene activation. Number 2 is hypermethylation of promoter cytosine phosphate guanine or CPG islands, silences tumor suppressor genes like retinoblastoma 1 gene and mute long homolog 1. Number 3 are altered histone acetylation through mutations in histone acetyl transferases or HETs or overexpression of histone deacetylases, HDACs, which affects chromatin accessibility. Then tumor microenvironment or TME interactions. A dynamic ecosystem of fibroblasts, immune cells, endothelial cells, and extracellular matrix. Cancer-associated fibroblasts or CAFs release growth factors while tumor-associated macrophages or TAMs produce interleukin 10 or IL-10 to suppress immunity. Hypoxia stabilizes hypoxia-inducible factor 1 alpha, HIF1 alpha, inducing vascular endothelial growth factor or VEGF-mediated angiogenesis. Moving on to stages of carcinogenesis. Number 1, initiation. The initiation stage involves irreversible genetic damage from carcinogens such as benzo(a)-pyrene, tobacco smoke, or UV radiation. Mutations often arise in Kristen rat sarcoma viral oncogene homolog or KRAS or TP53 genes. If unrepaired, these lesions are fixed during replication, producing permanently altered initiated cells. Then promotion. Promotion is a reversible stage where initiated cells expand under non-mutagenic influences. For example, it includes forable esters activating protein kinase C or PKC or hormonal stimuli like estrogen promoting cell growth. Chronic inflammation via cytokines such as interleukin 6 also accelerates clonal expansion. Third one is progression. In progression, cells accumulate further mutations, such as myelocytomatosis, viral oncogene homolog, amplification or phosphatase and tensin homolog, PTEN loss, promoting invasion and metastasis. Genomic instability drives heterogeneity, while angiogenesis sustains growing tumors. Epithelial mesenchymal transition facilitates this migration. Last, we have termination. This stage marks advanced malignancy, where tumors become autonomous, therapy resistant, and associated with systemic effects like cachexia. Mutations in multi-drug resistance protein 1, MDR1, contribute to drug resistance, complicating treatment outcomes. Dear students, let's talk about molecular pathways in cancer development. We see cell cycle dysregulation. The cell cycle is controlled by cyclin-dependent kinases, CDKs, complexes, and checkpoint proteins. In cancer, cyclin D, CDK4/6 hyperactivation or RB1 loss leads to unchecked G1S transition. Mutant TP53 further abolishes checkpoints. Cyclin-dependent kinases 4 and 6, CDK4 and 6 inhibitors like palbociclib exemplify targeted therapies exploiting these pathways. Then we have apoptosis resistance. Normal cells undergo apoptosis when damaged. Cancer cells evade this via B-cell lymphoma 2 overexpression, common in follicular lymphoma due to T1418 mutations in pro-apoptotic genes like BCL2 associated X protein or Bax protein. Targeted drugs such as BCL2 homology domain 3 mimetics, venetoclax aim to restore apoptosis. Then we have metabolic reprogramming. Cancer cells adopt the Warburg effect, favoring aerobic glycolysis even in oxygen-rich environments. This supports rapid biomass production. Positron emission tomography or PET scan imaging detects altered glucose uptake in tumors. Inhibitors like 2-deoxyglucose are explored to disrupt cancer metabolism. Then we see immune evasion. Tumors evade immune detection by expressing checkpoint proteins like programmed death ligand 1, PDL1, which inhibits T-cell activity. Checkpoint inhibitors, for example, pembrolizumab targeting programmed cell death protein 1, restore anti-tumor immunity and represent a major breakthrough in cancer therapy. Then we see genetic basis of cancer. Oncogenes. Their students mutated or overexpressed proto-oncogenes drive abnormal growth. Example is rat sarcoma viral oncogene homolog or myelocytomatosis viral oncogene homolog and human epidermal growth factor receptor 2. There are certain mechanisms like point mutations, CRAS in colon cancer, amplifications like HER2 in breast cancer, translocations, breakpoint cluster region, Abelson murine leukemia, viral oncogene homolog like BCR-ABL in leukemia. Dear students, there are certain tumor suppressor genes. Loss of function mutation prevent control over proliferation. Like TP53 regulates repair and apoptosis mutated in 50% of cancers. Retinoblastoma 1 loss drives retinoblastoma and multiple carcinomas. Adenomatous polyposis coli or APC mutation underlie familial adenomatous polyposis. DNA repair and stability genes. Their students' repair gene mutation cause genomic instability. Mismatch repair genes like MLH1 and MSH2 mutations cause Lynch syndrome. BRCA1-2 mutations cause breast and ovarian cancer predisposition. Then we see chromosomal aberrations. Structural, translocation, deletion, duplication, numerical, aneuploidy, polyploidy, all of these are mutations. Example, Philadelphia chromosome, T922 in leukemia. Moving on to causes of cancer. Causes of cancer are molecular, environmental, and lifestyle perspectives. Genetic mutations. The core of oncogenesis are oncogenes and tumor suppressor genes. At the cellular level, cancer begins with a genetic mutation that disrupt normal regulatory mechanisms. Oncogenes act like accelerators promoting cell division. Mutations that activate them transform normal proto-oncogenes into oncogenes, pushing cells into continuous proliferation. Then these tumor suppressor genes function as brakes, ensuring controlled growth. Mutations that disable them remove this restraint, permitting unchecked division. Together, these mutations create a balance shift where cell proliferation overrides regulatory signals, resulting in tumor initiation. Dear students, let's talk about inherited versus acquired mutations. Inherited or germline mutations, they pass from parents to offsprings and accounting for about 5 to 10% of cancers. Examples include BRCA1-2 mutation in breast and ovarian cancer and APC mutations in familial colorectal cancer. Then acquired mutations or somatic mutations. They arise during a person's lifetime due to carcinogen exposure, radiation or replication errors. These are the majority and highlight the role of environment and lifestyle in cancer developments. Students, let's talk about carcinogens, the agents that damage DNA. Carcinogens are physical, chemical, or biological agents capable of altering DNA and initiating the cancer. Number 1 is tobacco smoke. Tobacco smoke contains over 7,000 chemicals, including at least 70 potent carcinogens, such as polycyclic aromatic hydrocarbons and nitrosamines. These compounds form DNA abducts, particularly in the p53 tumor suppressor gene, leading to mutations that disable normal growth control. Smoking accounts for 30% of cancer deaths in the US, with strong links to lung, throat, bladder, and pancreatic cancers. Moving to second one, alcohol. Alcohol is metabolized to acetaldehyde, a compound that damages DNA and inhibits repair mechanisms. Chronic consumption increases the risk of liver, breast, throat, and esophageal cancers, and its effects are amplified when combined with tobacco use. Moving on to environmental pollutants like asbestos fibers, they cause lung inflammation and mesothelioma. Benzene is linked to leukemia. Industrial chemicals and pesticides induce DNA mutations over prolonged exposure. Then we see radiation and cancer. Ionizing radiation, their sources are X-rays, gamma rays, nuclear fallout. Mechanism of ionizing radiations. These radiations generate free radicals that break DNA strands, causing chromosomal rearrangements and mutations in tumor suppressor and proto-oncogenes. Moving on to associated cancers, leukemia, thyroid cancer, breast cancer. Ultraviolet radiations. Dear students, UVB rays from the sun are a major cause of skin cancers, including melanoma. UV induces thymine dimers and other mutations in DNA, leading to mutational signatures that disable growth control. And last, we see lifestyle and behavioral risk factors, that is diet and nutrition. Cancer-promoting diets are high intake of processed meat, red meat, and unhealthy fats. These increase the risk of colorectal, pancreatic, and breast cancer. Cooking methods like grilling and smoking generate carcinogens. like heterocyclic amines and polycyclic aromatic hydrocarbons. Moving on to protective diets like fruits, vegetables, whole grains, and foods rich in antioxidants. For example, vitamin A, C, E, and phytochemicals reduce DNA damage and inflammation. Physical activity and obesity. Physical inactivity increases risk of colorectal, breast, and endometrial cancer. Obesity is associated with excess estrogen production and inflammatory mediators that drive tumor growth, particularly in breast, endometrial, and kidney cancers. And last, we see smoking and alcohol together. The synergistic effect of tobacco and alcohol dramatically heightens risk for cancers of mouth, throat, and esophagus. Dear students, there are certain infectious agents which cause cancer, like viral oncogenesis. Approximately 15% of cancers worldwide are linked to viruses. Number one is human papillomavirus. Oncoprotein E6 and E7 inactivates P53 and retinoblastoma, causing cervical cancer. Then we see hepatitis B and C viruses, hepatitis B virus and hepatitis C virus. Chronic infections leads to liver inflammation and hepatocellular carcinoma. Then Epstein-Barr virus or EBV, associated with Burkitt's lymphoma and nasopharyngeal carcinoma. Or human T-cell leukemia virus or HTLV. It's linked to adult T-cell leukemia. Bacterial and parasitic agents. Helicobacter pylori infection, chronic gastric inflammation and stomach cancers. Chronic parasitic infections. For example, schistosoma hematobolum is associated with bladder cancer. Then students, let's talk about genetic predisposition and age. Familial cancer syndromes. The BRCA1 and 2 mutations are associated with breast and ovarian cancer predisposition. APC mutations are associated with familial adenomatous polyposis or colon cancer. TP53 mutation is associated with Li-Fraumeni syndrome, predisposing to multiple cancers. Age as a risk factor. Cancer incidence increases with age due to cumulative effects of mutations over time. The multi-step model of carcinogenesis emphasizes that multiple hits to oncogenes and tumor suppressor genes are required before malignancy develops. Immunity, stress, and cancer is also involved. A competent immune system detects and eliminates abnormal cells before they develop into malignancies. Immunosuppression due to HIV infection, organ transplantation drugs, or chronic stress reduces surveillance, increasing cancer risk. The link between chronic inflammation and tumor genesis is well established, as inflammatory mediators stimulate angiogenesis and suppress apoptosis. Moving on to molecular mechanisms linking causes to cellular events. DNA adduct formation. Carcinogens like PAH binds DNA, leading to replication errors. Chromosomal instability. Radiation and mutations cause breaks, deletions, and translocations. Epigenetic alterations. Environmental exposures may silence tumor suppressor genes or activate oncogenes without altering DNA sequence. Metabolic stress. Obesity and diet-driven metabolic changes activate growth pathways such as mechanistic target of rapamycin mTOR pathway and insulin-like growth factor 1, that is IGF-1, promoting tumor growth. Dear students, let's move on to case studies in cancer. Case studies provide real-world insights into how genetic alterations drive cancer progression and guide the development of targeted therapies. Number one is lung cancer. Tobacco-induced KRAS mutation initiates lung cancer, promoted by inflammation. EGFR, TP53 mutation drive progression. Epidermal growth factor receptor inhibitors and immunotherapy improves survival. Then number 2 is breast cancer. BRCA1 and 2 mutations initiate hereditary breast cancers. HER2 amplification promotes growth. Trastuzumab and poly-ADP ribose polymerase inhibitor or PARP-I target these. Then we see colorectal cancer. APC mutations initiate polyps. KRAS promotes adenomas. TP53 enables malignancy. Lynch syndrome highlights MMR defects. Another one is cervical cancer. Oncoproteins E6 and E7 of human papillomavirus inactivates TP53 and retinoblastoma with inflammation promoting progression. Vaccines prevent this infection. Moving on to treatment of cancer. Cancer treatment has advanced tremendously. The choice of treatment depends on the type, stage, location, patient health and spread of cancer, as well as the patient's overall health. Modern strategies aim to destroy cancer cells effectively while reducing harm to normal cells. Number 1 are conventional treatment approaches, that is surgery removes tumors and surrounding tissues. Best suited for cancers that have not spread. And limitations are complete removal is often difficult if margins are unclear. Number 2 is radiation therapy. Uses high energy X-rays or particles to destroy cancer cells. Radiation can shrink tumors before surgery or kill remaining cells afterwards. And side effects are fatigue, skin irritation, tissue damage. Moving on to chemotherapy. Chemotherapy employs drugs that target rapidly dividing cells, administered orally by injection or infusion. And what are the common side effects? It includes hair loss, nausea, and lowered immunity. Moving on to modern therapeutic strategies. Immunotherapy. Immunotherapy activates the immune system to combat cancer using checkpoint inhibitors. For example, nivolumab or pembrolizumab, chimeric antigen receptor T-cell therapy, or CAR-T therapy, and cancer vaccines, proving highly effective against melanoma and certain leukemias. Dear students, let's talk about targeted therapy. Targeted therapy focuses on specific genetic mutations or proteins in cancer cells using drugs like imatinib, BCR-ABL in leukemia, or trastuzumab, HER2 plus breast cancer, and geftinib, EGFR mutant lung cancer, offering greater precision and lower toxicity than chemotherapy. Then we have hormone therapy. It's used in hormone-dependent cancers such as breast and prostate. Drugs like tamoxifen, breast or leuprolide block or lower hormone activity. Moving on to stem cell or bone marrow transplant. It replaces damaged bone marrow with healthy stem cells and is used in blood cancers like leukemia, lymphoma, and myeloma. Palliative and supportive care. Dear students, it aims to relieve pain, stress, and fatigue. It improves the quality of life alongside curative treatments. Molecular and advanced therapies. Gene and epigenetic therapies. For example, CRISPR-Cas9 corrects cancer-causing mutations. Epigenetic drugs like HDAC inhibitors, Warenstat, reverse abnormal gene silencing. miRNAs and INC-RNAs are being explored as therapeutic targets. And we have nanotechnology in therapy. Nanocarriers improve drug delivery and reduce side effects, allow precise targeting of tumor sites with minimal damage to normal tissues. Combination therapies. Combining therapies enhances effectiveness and reduces resistance. For example, B rapidly accelerated fibrosarcoma or BRAF, and mitogen activated protein kinase MEK inhibitors with immunotherapy in melanoma. Then moving on to epigenetic regulation and cancer. Number one is DNA methylation. Hypermethylation silences tumor suppressors, for example P16, while hypomethylation activates oncogenes. Number two is histone modification. Abnormal acetylation or deacetylation alters gene expression. Non-coding RNAs, miRNAs, for example microRNA 21, and long non-coding RNA, they regulate the tumor growth. Therapy. Drugs like azacitidine, DNA methyltransferase or DNMT inhibitor, and vorinostat, histone deacetylase, they target reversible epigenetic changes. Dear students, let's discuss a bit about future directions and challenges. Number one is emerging therapies. CRISPR-based therapies, oncolytic viruses, and mRNA vaccines, for example, for pancreatic cancer, represent frontiers. Overcoming resistance. Resistance via MDR1 or alternative pathways limits therapy efficacy. Ethical and regulatory issues, dear students. Ethical challenges include equitable access to precision therapies and CRISPR's off-target risks. Global cancer burden with rising incidence in low-resource settings. Dear students, as we conclude these topics, your enhanced understanding of the genetic, epigenetic and environmental drivers of cancer equips you to pioneer transformative research. By harnessing advanced tools such as CRISPR and immunotherapy, you hold the potential to help transform cancer into more manageable condition. This knowledge goes beyond academics. It provides a strong foundation for innovative inquiry, enabling you to critically analyze cancer biology and contribute meaningfully to the advancement of scientific discovery. Thank you, dear students. We'll meet again.